Hello, this is Max Knight. I'm a first year doctorate in athletic training student through the Indiana State University Doctorate of Athletic Training program. And today we'll be going over my gaps in comprehensive lower extremity evaluation. So we're going to get started here. So first, one kind of like big gap I have right now as I've started practicing is understanding the patient outside of their injury. So kind of going outside the physical impairment, the pathology, the things that you can see, and the signs and symptoms that they present, at the clinic or in your athletic training room. So generally, what I usually do is, I just gather a medical history, understanding if there's anything in their family medical history, previous injuries, things like that, that have led up to this point. I try and understand the injury, getting a mechanism, how it happens, and then I go through the evaluation, I find a diagnosis, and then we either refer, give a home rehab plan, or have them stand or sit at practice. And I don't often think about what's going on in their head, how have our decisions made from a diagnosis and plan affect the patient's life outside of school and outside of their sport. How will it affect them at home? Is this going to put some strain on family members, kind of things like that. So moving forward, a way to look at filling in this gap of not looking at the patient outside of their physical injury would be utilizing disablement models. It's something we've talked about so far, and I've heard it being brought up plenty of times, but I've never thought about implementing it. So why? Like it says here, athletic trainers are great at only seeing the physical side of an injury rather than psychosocial components. So, and it helps understand the level of disability, by looking at health-rated quality of life measurements, and it helps look at all dimensions to help improve patient outcomes. So, with this, I could start with one of the first disablement models, the Nagy model. It looks at 4 dimensions: the pathology, the impairment, the functional limitations, the disability. And I think this would be a great way to start changing up how I document. So I'd go through the same SOAP format, but then in the subjective component, I would start with these, or I'd end maybe with these 4 dimensions. And this would kind of, make me, begin to ask more questions, more on the disability side of things, to see that person's relation to society, to ask questions, how this is going to affect them and their roles as an athlete, as a student, as a brother or sister, son or daughter, or worker at the grocery store. So again, like it says here, kind of change how I document, incorporate this model in my history, my subjective section of the evaluation, and I should focus on using this more with long-term patients that may have injuries that I know I'll be spending a little bit more time with rehab, reevaluations, things like that. So this would be a good way to kind of start small with a couple patients that I'll kind of be working with for a little bit here. The next gap is utilizing the hip to reduce knee pain. I've had a few patients so far the past couple months that have knee pain, and a few times I get stumped, and I'm like, okay, I don't know where this is coming from, and I just look at the knee. I don't think of, oh, hey, maybe I should look at the ankle, or oh, hey, maybe I should look at the hip, look at the pelvic tilt or things like that. So like it says here, I get narrowed vision on knee pain. Like lies I tell myself, like the pain can only be coming from the knee joint. Well, that's false. I need to look at the hip and or the ankle because there could be something there that may be causing issues at the knee. It's all part of a kinetic chain. So we're going to use an example such as lateral tracking of the patella with patellofemoral pain syndrome. The causes of this could be a neuromuscular imbalance with the VMO, the VLO, tightness in the hamstrings, gastroc, IT band, or overpronation with the talar joint or the ankle. Also, hip musculature weakness can play a role. With the movement of the femur causing patellar pain. And these are just a few examples from the literature that will start stimulating the thought process of, oh, hey, maybe I should start looking, at these different extremities. So how do I fill in the gap? So again, looking at the literature, it was found that poor strength with hip adduction and external rotation can contribute to PFPS. Isolated hip strengthening versus isolated quad strengthening prior to closed kinetic chain exercises have shown improved patient outcomes with pain reduction in knee pain. And at minimum, clinically, I should incorporate range of motion and manual muscle testing in my evaluations of the hip to find any weaknesses or any clues that may lead to knee pain from that extremity. And then as far as a rehab component, start to incorporate closed kinetic chain exercises like wall squats with ball squeezes, and then supplement them with isolated hip abductor and external rotation exercises to kind of help, have that 1-2 punch with significant reduction to PFPS pain. So, like using the literature here, this helps me understand, kind of things to look for and to really reinforce that, I need to look at, above and below. I need to have a full, complete, passive, active, resistive range of motion testing, and I need to reinforce or reiterate to myself that I need to manual muscle test as much as possible, because there could be that just that one thing that I don't test or I don't look at, which can give me all the information I need, and I can miss it by being lazy. So this will only help me get better. And then next, another gap I have is utilizing the hip to solve low back pain. I generally feel comfortable with low back pain cases. I often rush through and end up not using or coming to a proper conclusion or consensus. Low back pain can be caused by a pelvic tilt, leg length discrepancy, weak musculature, tightness in the musculature. So how can I fill in the gap? I can start using a plumb line to assess any postural abnormalities. I can, I need to make sure I need to look at, the ASIS, the PSIS, perform long sit test, assess leg length discrepancy. Again, manual muscle test, get a full range of motion assessment. And again, just kind of reiterate and reinforce, complete full testing of all objective measurements as far as manual muscle testing and range of motion at the different extremities. So again, these were the gaps of my lower extremity evaluation. Thank you for watching.